Hello and welcome once again to Minds That Matter. I'm your host, James Thomas. And today we have a very special guest, Dr. Walter Fitzhugh, who is the medical director for Lincoln Psychiatric Services. Is that correct?
That's correct.
Welcome.
Thank you.
Great to have you here.
Great to be here.
All right. Well, we have found out that you are an addiction psychiatrist.
That's correct.
Which I think is unique to Rhode Island. I'm not sure there are very many addiction psychiatrists in Rhode Island. Is that true?
Well, there's a sizable number of us. Actually we have a branch of the American Society of Addiction Medicine here in Rhode Island, and I think we boast 30 or 40 members, and there's plenty of psychiatrists. In fact, I would have to say that probably all psychiatrists in Rhode Island, if not all physicians in Rhode Island, do practice addiction medicine on one level or another. It's just that people that are certified in addiction medicine have had additional training beyond the standard scope of medical school and residency to specialize in this area.
Well, the term that we use at Riverwood is co-occurring disorders, dual diagnosis. You work with patients that have that diagnosis, that have both a mental health issue as well as an addictions issue? That's
correct, and really it's, in this population, it's kind of hard to flesh out one versus the other, because certainly with addictions there's inevitably a co-occurring mood disorder.
Okay. Now, we were talking prior to the show about the sort of, how do you define whether the person has a co-occurring disorder, or whether, like we were talking about a person who's being detoxed from alcohol, for example, and they may be presenting with some depressive symptoms, but it doesn't mean that they necessarily have depression. It just means that it could be just a function of the detox and the effect of the alcohol, that it could have created a depressive mood, but it doesn't mean that they have major depression. How do you kind of sort that out in your practice?
Well, when somebody's in the very early stages of withdrawal, if they've abruptly stopped the substance they were using, whether it's alcohol or narcotics, any substance of abuse, they are going to go through what appears to be a depressive episode where they have some mood dysphoria, they're feeling pretty awful, certainly they're feeling physically awful in the cases of narcotic withdrawal and alcohol withdrawal, and it's easy to jump to the conclusion that these people are depressed. However, the Diagnostic and Statistical Manual, which is what all psychiatrists are supposed to be following, states that in order to make a diagnosis of a mood disorder such as depression, it has to be in the context of sobriety for at least the previous 2 weeks. So it ends up being a little bit confusing. Is this patient's mood disorder that we're seeing due to the withdrawal, or is it due to the fact that they do have an underlying mood disorder? And that's where it can be very helpful to have family come in and or spouses and give us a history of what they see as whatever the patient's baseline was prior to the use. Unfortunately, sometimes these abuse disorders may have started in the early teenage years, and they've always been this way. And in terms of priorities, the first thing we need to do is to get the patient safely detoxed and then address what lies underneath.
Okay. Now, so the timeline obviously is very important. If there was a pre-existing mental health issue, it ought to be present prior to the use of substances, and or the family can give some information around that.
That's correct.
With something like schizophrenia, obviously that's another one where folks will, there used to be the talk about people self-medicating.
Correct.
To deal with auditory or visual hallucinations, things of that nature.
Correct.
And what is it? Was I psychotic because I was on LSD or on crack or on alcohol, or was I psychotic prior to that? And then that's what, I am in fact a full-fledged schizophrenic, and it's not that the substances have made me that way.
Right, and early in the diagnosis of schizophrenia, which usually you see emerging in the late teens, early 20s in males, and the mid-20s in females, they usually go through a period of hospitalization where the doctors get a sense of what their baseline schizophrenia is and how they can treat it adequately. So if they're if they subsequently start using drugs of abuse, I think that you're going to have some notion that this person's baseline is psychotic, that they do have a baseline thought disorder, that they don't see reality the way the rest of us see it. And in that case, it's really important that their psychiatric medications are maintained throughout the detox period.
Is there a certain antipsychotic medication that's preferred for working with a person with co-occurring disorder, or is it moot?
Well, it's really kind of moot. There's sort of two broad classes: the typicals, which would be the older agents, thorazine and Haldol and stelazine, and the newer atypical agents, which affect more of the serotonin receptors as opposed to the purely dopamine receptors of the earlier agents, and that would be the olanzapine or Zyprexa or Spiridone, Abilify, Seroquel. And what I notice around here, the patterns in the detoxes or in the hospitals around Rhode Island, that it doesn't seem to be they often select the antipsychotic based on its capacity to be sedating, since a lot of these patients can feel quite agitated early on, and it helps them feel a little calmer during the day and help them get a good night's sleep. But there's no one specific antipsychotic that's necessarily geared towards addictions or withdrawal.
Are there any meds that you've ruled out because of some of the medical implications or indications or contraindications? Like, there's been a lot of talk about Zyprexa, for example, as kind of a medication that can create weight gain, which can create diabetes, which has all sorts of things of that nature. That creates a fear around folks using certain meds. Anything you stay away from?
Well, sure. Things that, unfortunately, like Zyprexa, which is a great medication that does cause or can cause an increase in the lipid panel and give people propensity for a type of diabetes. That is something you'd want to avoid, especially in somebody who's already overweight. And there are a couple others in that category. The condition that where the practice of medicine comes in on a little bit more sophisticated level is the withdrawal of alcoholics. Since the alcohol's primary target is the liver, we want to use medicines to help them with, it actually brings up another point, is that when people are withdrawing from alcohol that have been chronically drinking, they're at a high risk for having withdrawal seizures. And what seems to increase the propensity for seizures is a pattern of drinking and stopping and drinking and stopping and drinking and stopping. The idea being that each time somebody does that, they're lowering their seizure threshold until they finally have a big withdrawal seizure, which is awful for their brain, awful for their heart, awful for their body. So we would want to use a medicine that will prophylax or prevent seizures in early alcohol withdrawal. And those medications, unfortunately, are metabolized by the liver, many of them, and so we have to be careful to respect the fact that their liver function isn't very good, and at the same time protect them from having withdrawal seizure.
Are you talking about lithium, Depakote, Tegretol?
Well, lithium
is
lithium is in a different class because that's purely seen as a mood disorder, and that's metabolized by the kidneys. But certainly Depakote is a big one, and it's a medication that I like to use for alcohol withdrawal. That's the big one. The other one would be carbamazepine or Tegretol. But both of these are, although they're good at preventing seizures, unfortunately do have the capacity to cause liver problems.
Okay. Well, we were talking again prior to the role of psychiatry in the mental health system. And you had mentioned you thought that was a good question, so I figured I would ask you that. A lot of people talk about psychiatrists as being pill pushers, and I mentioned that to you, and you said yes, that is one of the stereotypes that happens. But from your perspective, what is the role of a psychiatrist in the continuum of mental health for folks?
Well, within the backing up a little bit, within the context of medicine, I think that it's often been seen as kind of a joke. There's the old yarn that you hear in medical school that internists know everything and do nothing, surgeons know nothing and do everything, pathologists know everything and do everything, but it's all too late, and psychiatrists know nothing and do nothing. And that's, I think, how we're often seen. And part of it is certainly psychiatry's fault, because we were considered a fairly, especially in the 1950s, there were some great things that were happening in psychiatry at that time, not only the development of Thorazine, but also a lot of in the areas of psychotherapy and psychoanalysis. And the psychiatrists in the 1970s and 80s began to embrace psychopharmacology because there's really an explosion of some really tremendous agents, starting with Prozac in the early 1980s, where people did get better faster. In the meantime, the emphasis on medicine and psychiatry training had been decreased. It used to be you would have to do a year of a rotating internship where you'd spend times in medicine and obstetrics and surgery and the emergency room, et cetera. And now it's been reduced to, at least at the Brown program, it's 4 months of medicine, 2 months of neurology, and the rest is psychiatry. And I think that part of the problem is that a lot of psychiatrists early on lose their identity as a physician, which now more than ever we really need to be thinking like a physician, because a lot of these agents that we're prescribing are very sophisticated and can have some serious long-ranging potential problems. Psychiatrists are seen as pill pushers, and I think part of it is because psychiatry has sort of painted itself into a corner in terms of reimbursement from insurance companies. The insurance companies have come along and said, well, that's fine that you have training in psychotherapy, but you cost too much. We want you just to prescribe pills, and you'll get reimbursed nicely for that, but we're going to have lesser paid people that are, I think, lesser trained, such as social workers or people with a master's level degree, to do the therapy, and we just want you to prescribe medications. Well, at some point in one's career, it does start to feel like it's an assembly line where you're just doing nothing but writing prescriptions. And it's important to remember that antidepressants as a group are only effective to treating depression 40 to 50% of the time. Mm-hmm. So almost 60% of the time, that antidepressant isn't going to work. They almost always have side effects, and I found that they almost always lose their effectiveness or have this poop-out phenomenon over a period of time. Plus, they interact with, or they can interact, in some cases lethally, with other agents, although it's rare. And so it's kind of complicated. And the other issue is that we live in a society where people want a quick fix. You know, they don't want to lose weight. They want to get surgery to lose weight, and they don't want to be depressed or work through why their particular pattern of dealing with issues isn't helping them. They just want a pill to change their personality.
Yeah, my theory on that is that television has aided the notion that in a half hour with 3 commercial breaks, a world problem can be solved.
Correct.
So people are expecting things to get fixed real quick.
Right. Why not?